Okay, so you've got that stack of articles on your desk, and you need to know what's important about Maribavir for resistant or refractory CMV in solid organ transplant recipients. Well, particularly this Blumberg et al. Study. A subgroup analysis from the Phase 3 SOLSTICE trial published in November 2024. We're going to break it all down for you in this deep dive.
You know what's so fascinating about this is even with all our advances in prophylaxis, we still see these really tricky cases of CMV, rearing its head.
It's a constant battle. And then once those first-line antivirals fail, we're kind of in a tough spot.
Right.
Limited treatment options.
Right. Options like foscarnet and cytomegalovirus can be pretty rough on patients, especially those already dealing with all the side effects from immunosuppressants.
Yeah.
So this new data on Maribavir really gives us, I think, a much-needed deep dive into its potential for those resistant or refractory cases.
Okay, so let's set the scene a little bit. Why IS-resistant or refractory CMV such a headache? And what did this SOLSTICE trial set out to explore?
Well, as you know, CMV infection is a major concern after solid organ transplant. Even with prophylaxis, it can lead to all sorts of problems. Graft dysfunction, increased risk of rejection, and even impact patient survival. And, when we talk about resistant or refractory CMV, we're dealing with those infections that just don't respond to the first-line treatments like ganciclovir or valganciclovir.
Right.
So you're left kind of scrambling for other alternative options,
Right.
which often come with a whole host of toxicities.
Right, and that's where this SOLSTICE trial comes in. It investigates Maribavir, which is a newer antiviral in both hematopoietic cell transplant and solid organ transplant recipients. But for this deep dive, we're really zeroing in on the data specific to that solid organ transplant subgroup, which gives us a really granular look at its efficacy and safety in that population.
Yeah.
So before we get into the specifics of how they measured those outcomes, let's unpack the study design and who exactly these patients were.
Okay. So SOLSTICE was a randomized open-label trial comparing Maribavir to investigator-assigned therapy. It's important to note that in the Maribavir arm, patients received a fixed dose of 400 milligrams twice a day.
Okay. And what about that investigator-assigned therapy arm?
Yeah, so the investigator could choose from ganciclovir, valganciclovir, foscarnet, or cytomegalovirus. They could even use a combination of two of those drugs, really reflecting the kind of decision-making that happens in the, real practice.
Yeah, it's like a real-world test of Maribavir against the usual suspects.
Yeah.
So how long were these patients treated for?
Well, treatment went on for 8 weeks, with a 12-week follow-up period, allowing them to capture both the short-term and then the longer-term outcomes.
Okay, makes sense. Now onto the patient population. What were the specific inclusion and exclusion criteria?
Sure. So the patients had to have confirmed CMV viremia, meaning 2 consecutive positive CMV DNA tests. Their infection had to be refractory to at least one of those 4 standard treatments we mentioned: ganciclovir, valganciclovir, foscarnet, or cytomegalovirus.
So these were really the patients who had already failed at least one attempt to get this virus under control.
Exactly. And to be included, they also had to be at least 12 years old, weighing at least 35 kilograms, and with a life expectancy of at least 8 weeks.
Essentially, they had to be in a condition where aggressive treatment for CMV was warranted. Were there specific reasons why someone would have been excluded from the study?
Yeah, there were a number of exclusion criteria. So they couldn't have resistance or refractoriness solely due to non-adherence. It had to be a true treatment failure.
So they were really ruling out those cases where, the virus wasn't the issue, but rather the patient's ability to stick with the treatment plan.
Yes. And they also excluded patients with CMV disease affecting the central nervous system or retinitis. These are kind of more complicated manifestations that might require a different approach. Additionally, they couldn't be on medications like leflunomide, letermovir, or tessinet because of potential interactions with Maribavir or the investigator-assigned therapies.
All right, so they were really honing in on a very specific group of patients with this particular type of challenging CMV infection. Can you paint us a picture of the patient demographics in this subgroup analysis?
Sure. The majority of patients were male, and the most common transplant type was kidney. There were also smaller numbers of lung, heart, liver, and pancreas transplants included. All patients had a functioning graft at the start of the study. So now that we've kind of covered the study setup and who these patients were, let's dive into the results. I think you'll find them pretty interesting.
Okay. So what were the main outcomes they were tracking? And how did Maribavir stack up against those investigator-assigned therapies?
Yeah, so the primary endpoint, kind of the key measure of success here, was confirmed CMV viremia clearance at week 8. Essentially, could they get the virus out of the bloodstream by the end of treatment?
Makes sense. So getting rid of the virus is the ultimate goal. So
Yep.
did Maribavir hit the mark?
Well, it did. A significantly higher proportion of patients in the Maribavir group achieved that confirmed clearance at week 8, compared to the investigator-assigned therapy group. We're talking 55.6% for Maribavir versus just 26.1% for the investigator-assigned therapies. And that difference was statistically significant.
Wow. That's almost twice the clearance rate. That's a
Right.
pretty substantial difference. Do they break down the efficacy by organ type? I'm curious to know if Maribavir performed consistently across
Yeah.
the different transplants.
Yeah, they did. So for kidney transplant recipients, it was 59.5% in the Maribavir group versus 34.4% for the investigator-assigned therapy group. For lung transplants, the difference was even more dramatic, 47.5% versus 13.6%. And for heart transplants, it was 42.9% versus 11.1%.
Wow. So it seems like regardless of the specific organ, Maribavir seemed to have a pretty significant edge in clearing the virus.
Right. But it's important to remember that those numbers for the lung, heart, liver, and pancreas transplants are based on much smaller groups of patients. So while these initial findings are encouraging, we need to see data from larger populations to really confirm if those differences hold up.
Okay, so they looked at whether the virus was cleared. Did they also examine, how quickly that happened?
They did. The median time to first CMV clearance was actually shorter in the Maribavir group, 25 days compared to 30 days for the investigator-assigned therapies.
That sounds promising.
Yeah.
But was that difference statistically significant?
No, it wasn't. So while it's a positive signal, we can't definitively say that Maribavir works faster based on this data alone.
Okay, fair enough.
Yeah.
They also assessed CMV clearance A&D symptom control maintained through week 16.
Yeah.
What did they find there?
Right. So for that combined endpoint, the difference between the groups was not statistically significant. So while Maribavir seems to be better at clearing that virus initially, this study doesn't tell us conclusively if that advantage translates into a sustained benefit when you factor in symptom control over a longer period.
That makes sense. Did they look at any outcomes related to the transplanted organ itself? Did Maribavir pose any risk to the graft?
Well, there were very few cases of acute rejection in either group, and reassuringly, no cases of chronic rejection or graft loss during that study period. So it doesn't seem like Maribavir is putting that transplanted organ at any greater risk, at least in the short term.
Okay, that's an important point. It would be very helpful to clear the virus if it came at the cost of the organ.
Exactly. Now let's shift gears a little bit and dive into the safety profile. We've kind of hinted at it, but you've probably got some questions about how well tolerated Maribavir actually is.
Yeah. I'm especially curious about those adverse events they saw in both treatment groups.
Okay, so it's important to note that a very high percentage of patients in both groups did experience some kind of adverse event. We're talking 96.5% in the Maribavir group and 88.4% in the investigator-assigned therapy group. But here's the key. The treatment discontinuation rate due to those adverse events was much lower in the Maribavir group, only 3.5% compared to 23.2% in the investigator-assigned therapy group.
Wow. That's a huge difference. So even though many patients experience side effects, it sounds like they were much more manageable with Maribavir.
That's the critical takeaway here. The side effect profile is really very different between those two groups.
Yeah.
So in the Maribavir group, the most common treatment-related adverse event was dysgeusia. That taste disturbance we talked about earlier, it's generally not serious, rarely leads to treatment discontinuation, and it usually resolves either during treatment or shortly after.
Okay, so while not ideal, it sounds like dysgeusia is a relatively minor issue compared to some of the side effects we see with those older antivirals.
Absolutely. In contrast, that investigator-assigned therapy group saw much more serious treatment-related adverse events, things like neutropenia and acute kidney injury. Those are significant concerns. They can lead to infections and other complications. And it explains why more patients in that group had to discontinue treatment.
Yeah, that's a pretty striking contrast. So it seems like the safety advantage leans heavily towards Maribavir. But what about the elephant in the room? The risk of resistance.
Of course, we can't ignore that. Treatment-emergent mutations to Maribavir did occur in 28.2% of patients in this study.
Okay, so about a quarter of the patients developed resistance. That's definitely something we need to keep an eye on, especially as Maribavir becomes more widely used.
Absolutely. But let's kind of break down what happened to those patients who developed resistance. So out of those 40 who developed mutations, 33 went on to receive alternative anti-CMV medications. And of those, 19 or 58% were able to achieve CMV clearance.
Okay, so it's not a dead end if resistance emerges. There are still options.
Exactly. And this data really highlights the need for continuous monitoring and vigilance. We need to be proactive in identifying resistance early on. and adjusting treatment strategies accordingly.
Right. Speaking of adjustments, you mentioned earlier that maribavir can interact with certain immunosuppressants.
Right. Maribavir can increase tacrolimus and sirolimus levels,
Hmm.
which could lead to toxicity if those levels aren't carefully managed.
So it's not just about prescribing maribavir, it's about understanding its potential interactions
Hmm.
and monitoring patients closely.
Absolutely. Transplant physicians need to be aware of this interaction and consider potential dose adjustments for those immunosuppressants. This is where that close collaboration with pharmacists and the entire transplant team becomes so crucial.
Okay, well, we've covered a lot of ground here. What are your overall thoughts on the implications of this study? How does maribavir fit into the bigger picture of CMV management?
Well, I think this study represents a significant leap forward in our ability to effectively tackle those resistant or refractory CMV infections in solid organ transplant recipients.
So are we saying that maribavir is the new gold standard?
Well, I wouldn't go that far just yet. While it shows great promise, there are still some questions that need answers.
Like how its role might evolve with the increasing use of letermovir for prophylaxis?
That's a big one. Will we even see as much resistant or refractory CMV with letermovir in the mix? And if so, how will maribavir fit into that landscape? Could combination strategies become more prevalent? These are all areas for future research to explore.
Yeah, it seems like we're entering a new era in CMV management with some really exciting possibilities, but also a need for that ongoing vigilance and a personalized approach.
Precisely. And while this study gives us a lot to consider, there's always more to learn. I'd encourage everyone to dive deeper into the full study and think about how these findings might shape your own clinical practice.
It's clear that this Blumberg et al. Study, it's giving us a lot to chew on when it comes to managing these really tough CMV cases. As we wrap up our deep dive here, I'd love to kind of pull out the key pearls for our listeners and talk about, what this all means moving forward.
Yeah, definitely. Let's distill it down to those essentials. I think the major takeaway here is that maribavir really does seem to be a game changer for treating resistant or refractory CMV in solid organ transplant recipients. This study showed it to be more effective at clearing the virus than those standard second-line therapies. And with, a significantly lower risk of those serious adverse events that we often see with those older medications.
Yeah, that's a huge win for both clinicians and patients. It sounds like, maribavir has the potential to really become
Yeah.
a preferred first-line treatment for these challenging infections.
Yeah, I think that's a reasonable conclusion
Yeah.
based on this data. But we can't forget about those caveats. The risk of resistance developing, the potential interactions with immunosuppressants,
Yeah.
and the long-term implications of maribavir use. These are all areas that warrant continued attention and research.
Right. So it's not just about adding maribavir to our toolbox and calling it a day. We need to be thoughtful
Yeah.
and proactive in how we integrate it into our management strategies.
Yeah, exactly. This really calls for a shift in our thinking. We need to move away from that one-size-fits-all approach and embrace a more personalized strategy for each patient. Think about their specific transplant type, their immunosuppression regimen, their overall health status, and their individual risk factors.
Right. And let's not forget the importance of, patient preferences. This study focused on the hard data.
Yeah.
But we need to consider how patients feel
Oh.
about the different treatment options and involve them in that decision-making process.
Absolutely. Ultimately, our goal is to provide the best possible care for our patients. And that means taking a holistic view, factoring in both the evidence and their individual needs and priorities.
Yeah, I think that's a great point to wrap up on. This deep dive has given us some really valuable insights into that evolving landscape of CMV management. Maribavir is an exciting new weapon in our arsenal, but it's just one piece of the puzzle. As we continue to gather more data and refine our strategies, I'm optimistic that we can make even greater strides in preventing and treating these challenging infections.
I completely agree. The future of CMV management is bright, and I'm eager to see what the coming years hold.
Well, thank you for joining us on this deep dive. We'll continue to keep you updated on the latest research and developments in the field.